it is my pleasure to present to you today Dr. Amrik Singh Khalsa. I had the pleasure of meeting him on a bus, right? At the PAS, was it at the PAS? Yeah, at the PAS on a bus to we were going to the meeting, one of the dinners.
One of the dinners, I think.
Yeah, that I was like almost not going to go to. And Dr. Katie Forrester, a former alum of Children's Hospital, introduced us. And he is a recent inductee into SPR. So congratulations. So see how these things can happen in this world of networking. And I was pleased to meet him and cross his path. So to give you a few bit of background facts before we let him roll forward. And I'll ask everyone to hold their questions till the end, but if you have clarifying questions, please put them in the chat. Dr. Khalsa is an assistant professor of pediatrics at Nationwide Children's Hospital and which has been trademarked, The Ohio State University. He is a principal investigator at the Center for Child Health Equity and Outcomes Research within the Abigail Wexner Research Institute, and his research focuses on prevention of obesity and its comorbidities. And in his work, he's regularly partners with families from low-income households and minoritized populations. He is board certified in internal medicine and pediatrics, and congratulations, has an NIH Career Development Award to develop, assess, and evaluate the preliminary efficacy of a visual-based communication tool to convey disease risk to families. And with that, the floor is yours, sir.
All right, thank you. So let me know if you guys are not able to hear me okay or need me to change anything. So we'll do that. Great. Thanks so much for the lovely introduction, Beth. Yes, it's wonderful to see how networking can make such a big difference. And so that was a pleasure of mine as well to meet Dr. Trini, and a pleasure to be here today. It's great to join you guys virtually. Great introduction. And we'll start off with a little bit of brief background about myself. Where I've come from, and dive into some of the work that I have related to reducing intergenerational health disparities in chronic disease related to some visual-based communication tools. So definitely still within the sphere of obesity and its comorbidities, but a little bit more focused more recently. All righty. I have no financial or competing financial interest, but just some of the work presented was previously supported by a T32 grant awarded to Cincinnati Children's. And none of course, I think I'm supposed to say this, that none of the things that I have in my talk are any opinions related to HRSA, NERSA, any of the government stuff. It's all my opinions. All right. I think I gave a little bit of this, but just a brief professional background into pediatric obesity and longitudinal outcomes, the role of visual-based communication tools, and some current and future directions. All right, I like to start by telling everybody a little bit about myself and my career trajectory, and I like to do this for several reasons, but including to inform some of the junior investigators, and even a reminder to some of the other investigators that research is, never linear. It's always circuitous and running in circles. And it kind of gives you a little bit of background of where I've come from. So my research is largely focused in the medical problem of obesity and its complications, with the focus on prevention and family-based interventions. And my interest in obesity started in undergrad at the University of Michigan, and I worked, in a lab looking at the leptin pathway in mice. I am very thankful that I'm not working with mice directly anymore. Clinical research soon followed as I embarked medical school. You'll see a running theme here. I've already disappointed many Big Ten fans. I'm sorry. I worked in a large team at Michigan State in a pilot obesity prevention program in middle school children across several low-income schools throughout Michigan. And it was here where my interest in pediatric obesity prevention really sparked, and I became interestingly aware of the prevalence, but particularly in low-income families, but also recognized the limitations of just education, and educating risks of obesity. And as I continued my medical education, I learned that the increased risk children have of being obese as adults just because one or more of their parents have obesity. And so what further fueled my interest actually were the parents I started taking care of. They voiced their own struggle with obesity to me, and as a med peds trained physician, they often turn to me saying, well, I have XYZ comorbidities like diabetes and heart disease. I don't want my own child to struggle with these. How do I prevent this from happening? And I soon realized that there remain significant gaps in the literature, especially around the intergenerational prevention. My clinical expertise was definitely not enough, and I needed more research training. And while families often cite socioeconomic barriers, there are barriers that healthcare providers cited as well, including effective and efficient tools to communicate risk of obesity and or cardiovascular or other comorbidity diseases. And so, I was trying to think about how can we find ways to break some of these barriers. And so I decided to do a general academic fellowship and learn the research skills needed to conduct some quality research. And I learned a few things in fellowship. Besides all the papers, secondary analysis, writing grants, blah, blah, blah. But through my own research, I found that lifestyle behaviors in children start quite early, with parents influencing their child's eating behaviors maybe as early as infancy, right? And also found that healthcare providers delayed lifestyle counseling in families, particularly in those from disadvantaged backgrounds, until the child was maybe older or had a greater severity of obesity. And that's when more intensive lifestyle counseling was needed, but that may be too late. And so thinking back, when does prevention really need to start? Does it need to start in childhood or infancy? And an accumulation of my experiences have led me to my professional goal to be an independent clinician investigator focusing on improving outcomes and reducing the disparities in obesity and its comorbidities by designing interventions, family-based interventions that evoke motivation to change, facilitate progression into actionable steps, and augment the maintenance of behavior change in all families, but particularly focusing on low-income households and those who are minoritized. So, you'll see that my work kind of revolves around this sort of cycle of obesity, whether it be, from childhood to early onset, mother and child, back to the family. But the whole idea is that we work to sort of break this vicious intergenerational cycle. All right, enough of the graphics. All right, let's start by reviewing a few key numbers, as things I'm sure you guys already know, but just a review. So over 40% of adults and nearly 20% of children have a diagnosis of obesity in the US. Children who have a parent with obesity are nearly 2 to 3 times more likely to develop obesity in their lifetime compared to children who have a healthy weight adult. And children who develop obesity are more likely to remain with the diagnosis of obesity throughout their life, right? Which increases their future risk of comorbidities, including things like cardiovascular disease, diabetes, and so many more, just to name a couple, all right? Alrighty, so this graph I'm going to show you is from a recent article in the New England Journal of Medicine that really displays the lifelong risk of obesity. It's a simulation model that sort of estimated the risk of adult obesity, for children. And what they were trying to show is that, while 8%, may have a clinical diagnosis of obesity at 2, the prevalence could increase as high as 60% by the age of 35 if there were no interventions, right? This indicates that overweight and obesity will continue to be major health problems in the US, and ones that we've been trying to work on, but have maybe made small dents in. And unfortunately, there is socioeconomic disparities, so ones that are noted even as early as age 2, right? And one number from the CDC shows that 8.4% of those who identify as Black or African American have a clinical diagnosis of obesity, right? And that's versus 6% in white or Caucasian families. So you can see that these things start very early, and the disparities unfortunately only grow over time, right? These disparities in obesity, and then of course their comorbidities, persist throughout childhood. We've talked about some of those numbers. They continue even with throughout childhood, and unfortunately disparities, based on, are based on the disparities based on race and income have been ongoing probably for decades, if not longer. And several interventions and public health efforts have, as I mentioned, only made slight improvements. Although I think we're trying to find our way, I guess. With regards to cardiovascular disease, right? Those who identify as Black are twice as likely as those who identify as white to die of preventable cardiovascular disease, and there's similar trends in those from low-income households and those affected by obesity. There's great work that needs to be done. And while we've made strides in reducing the overall prevalence and mortality of CVD, really cardiovascular disease accounts for more than 6 million hospitalizations and 800,000 deaths per year. So prevention efforts are paramount. So why is prevention so important? When should prevention start? I'm sure you guys know the studies that show that physiologic changes, start very early on. We've got some examples from the Bogalusa heart study. But another one is that, lifestyle behaviors start fairly early and tend to persist throughout childhood. And I'll show you guys an example of this from my own work, a secondary analysis that I conducted in fellowship, and it was eye-opening to me on how early sometimes lifestyle behaviors were already suboptimal. So I'm going to show you guys some data from a secondary analysis I conducted in fellowship of the preschool eating activity studies, or PEAS for short. You'll love our acronyms here. And there was a 24-hour observational study of about 447 preschool children ages 3 to 6 from 30 full-time licensed childcare centers in the greater Cincinnati, Ohio area. And what I did was I examined the adherence to the 5210 recommendations. These are the sort of recommendations published by the AAP, created originally in Maine, but as for lifestyle goals for children to meet to prevent obesity. So let me show you this. It's a lot going on, but let me orient you. On the left over here, we've got sort of the 5210 definitions spelled out over here. I also have written the number of children from our sample who had complete data for each recommendation. The second column shows the median and the interquartile ranges for those definitions. And then the third column, the number of children who met the guidelines and any relevant demographic predictors. So let's take a look at the data, right? If we look at fruits and vegetable intake, we see that only 17% of preschoolers met the guidelines for fruit and vegetable intake, with a median intake of 3.1 servings. And this is based on, this is data collected from about 2011 or so. So it's based on the guidelines from back then, USDA guidelines from back then, and using serving size that are age appropriate. So we're about 2 servings below the minimum recommended intake. We also note that children in a household with an annual income between 25 to 50,000 had actually 0.16 more servings of fruits and vegetables, right, compared to those with an annual income less. So if you look at screen time next, we see that, of the, 380, I think, children with complete screen time data, most of them, 81% met the screen time data, but the total median watch time was 71 minutes. Interestingly enough, most of it came from home. Now, this is, of course, way before pandemic and probably before the rise of additional screens with telephone or phones, smartphones rather, tablets, etc. If we continue to look on to physical activity, we use the definition that was most prominent at the time, which was, using the expert committee recommendations in the AAP that recommended 60 minutes of moderate to vigorous activity. And, you can see that only about 3 children, or definitely less than 1%, met that. Now, there are alternative definitions which are more prominent now. It's, the National Academy of Medicine recommend 180 minutes of any activity. These are somewhat consistent with some of the other guidelines from other countries, including Canada and Australia. And so when we use that definition, about 98%, almost all of them actually met that goal. And then finally, if we look at sugar sweetened beverages, about half the children met the recommendation of 0 sugar sweetened beverages intake. And in households with annual incomes greater than $100,000 per year, children were 1/3 less likely to consume sugar sweetened beverages. All right, so in our sample, only 1 child out of nearly 300, had complete dietary, screen time, physical activity data, met all 4 of the recommendations. However, even when we expand using the alternative definition of physical activity, only about 8% of children met all 4 recommendations, a lot of these largely driven by low attainment of fruit and vegetable. And unfortunately, our findings were actually consistent with previous studies that have shown low attainment of our 5210 recommendations in school-age children. One study noting about less than 2% of children met all 4 guidelines and 1/3 of children met none. And that's very similar to our data, but it kind of shows and supports the notion that lifestyle behaviors, and maybe suboptimal ones rather, are quite early. And other studies have shown, ours is cross-sectional data, but other studies have shown that, longitudinal studies rather, have shown that lifestyle behaviors tend to worsen throughout childhood. They don't really get better, which is not great either. Oops, sorry about that. All right, so then made me ask the following. Well, how early are lifestyle behaviors set? Is it set by preschool age, maybe earlier, like toddlerhood or even infancy, right? Maybe, it's more, and maybe more importantly, who or what shapes these behaviors? And as a med-peds trained physician, I'm reflecting and considering what roles do parents have in shaping this risk, right? We know that breastfeeding and, versus bottle feeding, even bottle feeding breast milk can have an impact. What are the role of families or multiple caregivers? And, what do parents' role in shaping sort of this risk? And so, we know some of the socioeconomic, demographic, paternal anthropometric risk factors, right? Like, as I mentioned, parental obesity increases a child's risk, but we don't really quite understand all the mechanisms by which this is occurring. So, early habits, set early, but, how and why is this happening? So one of the things that I looked at to better understand this was I looked at the association between caregiver eating behaviors and the styles by which they feed their infants, also called feeding styles. Now, I'm gonna this is a lot of content here. I'm gonna go through and just kind of thinking about I'm gonna try to give you guys some of the overarching brushstrokes here. So, if we look at, feeding styles are the parental attitudes regarding how they feed their child. And more specifically, if you look at feeding practices, they're the behaviors parents use to achieve their feeding goals. So it's sort of, the emotional context and the actions that parents use within the specific types of feeding interactions. So now there are 5 different types of feeding styles in infancy and early toddlerhood, and they're sort of defined here. But to make it a little bit easier, I'm going to give you some examples in just a moment. In general, they're believed to be on a spectrum, right, between low parent control and high parent control. And so let me go and give you guys some examples as well. So we have restrictive, right? Restrictive is an example where mom carefully controls how much Johnny eats. In pressuring, mom encourages Johnny to finish his food even if he seems full. Jumping down the bottom left here, in laissez-faire, mom allows Johnny to eat while watching TV, and an indulgent mom allows Johnny to eat desserts or sweets to make sure he eats enough. Now, finally, we have responsive, and this is where Johnny decides how much to eat and knows when to full, and knows when he or she is full. So this is where mom or the caregiver, more largely, is aware of their hunger fullness cues, right? They monitor the quality of food provided. They're attentive to some of the cues, and this is considered sort of an ideal feeding style. All right, now the icons are definitely simplistic, but I'm hoping they serve a quick visual reminder when we show some of the data on the future slides. So I'm going to show you guys a table showing the Spearman correlations between the data that I looked at, looking at caregiver intuitive eating behaviors and infant feeding styles. So what we did in this on the left-hand side, you'll see we measured caregivers, their own eating behaviors. Do they eat for physical reasons rather than emotional ones? Are they relying on their own hunger and satiety cues? Are they giving themselves permission to eat things that are considered, positive ways to eat? And on the top, the infant feeding styles are the ones that I showed you guys just a moment ago. So if you look at the third column here, responsive feeding, this is sort of where the meat of the data is. A parent who relies on their own hunger and satiety cues, right? That's sort of what the caregiver intuitive eating behavior is showing. Actually, we're more likely to feed their children in a responsive feeding style. That is, to be more attuned with their child's hunger and satiety cues. And so this really, it's really focusing on this specific measure, right? The reliance on hunger and satiety cues, as I mentioned. Now, while there were other interactions as well, this really suggested to me that, what parents are doing, particularly when it's a positive behavior, they're, mimicking that for how they feed their children. And the research and fellowship, this suggested that parents and families at large, right, they eat, similar, they're trying to eat and feed their child in similar ways, and these things may be related. And indeed, this is sort of where the field is going, right? We're thinking about family-based intervention. So it's not just the fact that we see these, relationships early on, but even later in life as well. And I think the field has sort of picked up on this in the last 10, 15 years. There's been really a large focus, not necessarily just on the parent or the child, but really family-based interventions. And it's exactly that, right? The work with at least one caregiver and child to make up, improvement in their lifestyle behaviors. So family-based behavioral interventions, have been shown to be somewhat more effective strategies to reduce obesity and cardiovascular disease risk factors, so including some of the dietary and lifestyle behaviors. All right. However, participation in family-based behavioral interventions is quite low, right? Particularly in high-risk groups, including those who identify, as Black and those from low-income households. And they report numerous barriers, environmental barriers, and as many as you guys can understand and predict. And so research is really needed to sort of help identify practical, feasible, maybe even culturally relevant ways to convey, ways to sort of facilitate, progression and maintenance of behavior change. Now, while I completely don't want to ignore, right, all the socioeconomic factors, the environmental factors that prevent change, right? Things like crime, ability to have access to safe places to play, access to healthy food, fruits and vegetables. Those are all definitely important. But some of the research has shown that oftentimes when we make small measurable changes within the environmental context we have, that can sometimes lead us to not only push back on some of those environmental barriers, but sometimes also can help us change some of those behaviors. Now we need both, right? We need individual change, but we also need environmental change. And I'm happy to, I understand there's a little bit of push and pull here. I'm happy to take comments and feedback on that as well. So one of the family-based interventions that I was fortunate to work on was the Summer Harvest Adventure, which is a USDA-funded garden-based obesity prevention program for children from low-resource communities. It was a 12-week garden and health education program, including telephone-based motivational interviewing. This occurred during the summertime, really to prevent summer weight gain. And as you may or may not know, summertime, unfortunately, is a time where many children's diets tend to be tends to decline due to a lack of consistent meals, sometimes lack of, even supplemental access to the supplemental free and reduced breakfast lunch program through school. So things really decline, especially for some of our patients and population. So the main study recruited, parent and a child who was aged between 8 and 11 for this program. They had in-class session where they learned about some of the fruits and vegetables they were growing in the garden. They got to do taste testing. They had some recipes they could follow that were easy to make. They tried those recipes in class. And then the second half hour, they were out in the garden picking those fruits and vegetables. So they got to pick things that, they were, more likely to eat at home. Now, as a part of that, one thing that we collected was in collaboration with one of our partners was sonographic images of the children and their parents, specifically images of visceral adiposity and even carotid arteries. And in collecting these images, we saw that there was actually significant interest from both the children and the adults of what the images mean. They asked numerous different types of questions, like, what does this mean to health? And of course, our technologist who's not trained in this was like, well, you can ask your doctor, or we'll have the study team come follow back with you. And oftentimes the study doctor, myself, was, informing some of the more anxious parents and children. So we subsequently collected qualitative interviews with these families to see what did they really understand about these images, why it was being done, what did they believe, or how did they believe it related to their health. And while we're still analyzing the data, an emerging theme has been an increased interest in their health indices when seeing their own image, right? They seem more motivated to even potentially make a change in their behavior. Now, interestingly, when I look back at the data at large, recent randomized control trials have also shown in adults that, those who visualize some of their own risk factors or own health indices, including carotid intima-medial thickness, actually had improvement in their cardiovascular disease risk scores. Now, these are in adults, and these are done, sort of as a, screening tool, even though carotid intima-medial thickness is really kind of turned out of favor. But it was done in one of the European studies and showed that 1 year after sort of this visualization, there were some dietary changes that some of the patients or participants made, but also healthcare providers were more likely to engage in, cardiovascular disease risk reducing measures. So, for example, prescribing a statin or cholesterol lowering medication. So what do we know about visual tools and communication of disease risk? Well, we know that visual tools offer a more tangible, concrete means of communicating risk and can increase comprehension. They're emotionally evocative in many cases, or can be, and can potentially lead to behavior change. And so they include both graphical and illustrative images. I'm going to show you some examples in a few moments, and can really improve the understanding of risk, leading to potentially improvement in some lifestyle behaviors, both in adults and children. Now, while that may be the case, the data out there is actually quite limited, and a lot of it actually is from earlier on and uses some, more primitive visual tools. And current tools to convey health risk about obesity really do, and or even cardiovascular disease, really use more numeric communication, right? So they're using things like, oh, your 10-year risk of cardiovascular disease is 9-point-some%. So it's really, they're not always consistent with the field. Here are some examples of visual images that have been shown to be somewhat effective. And one on the left is a graphical expression of the risk of heart attack for 100 people with or without a medication. You can see it's very basic. We have other ones here. This is for childhood obesity. It's a color-coded BMI chart, which displays BMI into a healthy range, at risk, which is the overweight diagnosis in the yellow, and then red, which is both here, obesity and underweight as well. And the right here example is this is more for our angiography. But you can see balloon angiography on the top, and then success rate of bypass surgery. Now, this data here is quite outdated, I would say. We made some big strides in sort of angioplasty. So don't take this for, meaning that this is what you should be doing or recommended to patients. These are just some examples of visual communication tools. So while we've had some work in this field, there's, the amount of data in this area is quite low. And previous studies have really solely focused on, families who identify as white and those from upper income households. We also have not examined lifestyle changes across the family or even individual members, thoroughly. They don't really convey intergenerational risk, and oftentimes they're not targeted toward, certain populations. They don't really incorporate culturally relevant, counseling, and so the highest risk families who would probably most benefit from some of these tools have not been the focus of research. More on the flip side, though, from communication as being a two-way street. We've also got the healthcare providers, and healthcare providers are expected to counsel families about the long-term risk of obesity, especially in pediatrics, and what it has in terms of comorbidities, including cardiovascular disease risk, to sort of empower families to implement behavior change. But these strategies that are most effective and valuable to parents, those things like motivational interviewing, can be really difficult to implement in a busy, clinical setting. And so there is a need for effective, efficient tools that are, both engaging for the participants, the parents and their children, but then also, that's really important from a healthcare provider side, right? I'm looking at, how to best and effectively communicate this risk, because that can be very variable between providers. And again, the goal for these communication tools is really to motivate behavior change within the structure of a family. Oh, I guess I already talked about that. Sorry, a little bit behind on my clicking here. So in thinking about this and kind of exploring the literature, I came across what's, a long name here, an extended parallel process model, or the E-EPPM. There's a lot going on, but I'm going to walk through it. So this sort of was a guide on how to think about and develop effective communication strategies. It's important. So really an important part of any communication strategy is, looking at and maybe communicating threat appraisal, which gets divided into two parts, right? Perceived severity and perceived susceptibility to the disease. All right. The E-EPPM also notes that a communication strategy that modifies an individual's perceived threat, right? So both the perceived severity and or the perceived susceptibility will actually prompt an emotion, right? Either fear or anxiety. Now, if left completely unchecked, if we completely ignore the coping strategy, the coping appraisal piece of it, this can lead to it can actually lead to worse outcomes, because it can lead to denial of threat and potentially a riskier behavior. And this is because the individual's emotional response to the perceived threat, becomes a vital mediator. If their person's fear or anxiety, right, is high and their self-efficacy or response efficacy is low, that is that they don't believe they can actually make a change successfully, or that making a change will not lead to a positive outcome. It actually will lead to denial of threat and, again, the riskier behavior. So when you're building a communication tool, you need not only the threat appraisal, but also the coping appraisal. You need to help potentially think about, understand where people are at with their ability, their beliefs that they can make a positive change, and that the change will actually be a positive outcome as well. And so we need both of these things. And so in thinking about that, and thinking about if coping appraisal is also important, how can primary care providers help parents improve this? And it made me reflect on a project we conducted in fellowship where we attempted to do this using visual-based tools and scripted language grounded in motivational interviewing to really sort of enhance parents' motivation to make a change. In this study, we actually targeted parents of preschool-age children ages 24 to 66 months, and we asked families to rate their level of readiness to change by answering one question while being roomed. So the MAs or the nurses who were rooming them asked them, using the scale below, can you please point to how important you think it is to make a plan with the doctor today to improve your child's nutrition or physical activity? And they could rate any of the following numbers. And on the flip side, healthcare, there were this number that was communicated to the healthcare providers, and the healthcare providers were given templated, scripted language based on their definition, along with a whole host of other tools that we laminated and put in the rooms so they could use this to sort of counsel families, right? And this is all based on sort of their quote unquote readiness to change, right? And so I'm going to show you guys here in just a moment, actually right now, some of the examples of some of the tools we had. So once a provider came into the room, some of their language and what they talked about was guided based on the family's readiness to change. And one of the things, if they were ready, or if they felt that they would be somewhat ready to change, we had parents pick one of these items on the left goal menu, right? And providers had available to them, on the right here are some of the templated languages. This is created in based on the expert committee guidelines of in obesity, but also we work in consultation with MI experts as well. And all providers receive brief training in motivational interviewing through 4 to 6 sessions on MI, by an MI expert over a lunch session. So about 4 to 6 hours of training. So definitely not, enough to be fully trained in MI, but enough to sort of get some of the basics of MI. And so you can see, even if parents, said, they were pre-contemplative, we would say, well, it sounds like you're not interested in making a plan. But would it be okay if we provided some additional information to you today and ask you again on our next visit? Again, these are just some examples. There was a whole menu of choices that a provider could pick. We had other ones for contemplation and preparation as well. And if families, even if they were in the contemplative section and the provider was able to work with families to get to the preparation stage, we were then able to help them create a goal. And what we really emphasized was creating a SMART goal, a specific, measurable, attainable, relevant, and timely goal. And this goal was written out on a piece of paper with then 2 questions. How motivated are you to meet this goal, and how confident you are to meet this goal? Again, these are based on MI techniques, and really working with the family then to sort of, if they were not really confident or motivated, then to rehash some of those, that goal, to make it really, really specific. And so sometimes the goal is simple as, I'm gonna, have my child eat, or I'm gonna offer even one more fruit that, the next, one more fruit a day that week, or maybe even more specific if it needed to be, or less, less in smaller quantities. We followed this up by a phone call by one of our nurse health coaches in 2 weeks, and then an in-person clinic visit within 1 month. And what we found, so we evaluated charts from about 140 participants who had the diagnosis of overweight or obesity. Based on our sample, this is from our clinic here. So it was about 71% who identified as Black race. Nearly all of them had Medicaid insurance as well, or uninsured. And so what we found was that a co-development of a healthy habit goal improved with interventions. You can see that while not all of these goals items within the SMART goal improved, many of them, including the A, R, and T components, were statistically significant. Now, not large numbers, but still decent enough to be clinically relevant. The families were also more likely to return for a follow-up visit. Again, not high, 8 to 21, but still decent. And then they actually attended the FAAP clinic. Again, not the best. These are not the best numbers here. I recognize that, but still not only statistically significant, but I think even clinically significant as well. Now, while the project didn't really specifically measure self-efficacy or response efficacy, I think it still shows the power of brief behavior change counseling. And so going back to our theoretical framework here, for the communication strategy to lead to a protective action, in this case, mitigation of CVD risk, right? The communication tool has to support both coping, both not only provide the risk, but also support coping strategies. And my hypothesis is that a visual image, will probably evoke a change in perceived susceptibility, more than severity, although we could probably tailor it to do a little bit of both. But more importantly, a brief behavior change counseling will be needed to improve self-efficacy and response efficacy. Now, again, there are a lot of other things needed before actual change in behaviors occur, including the mitigation of the perception of environmental barriers or even the barriers themselves, action planning, maintenance of behaviors, all among a whole host of other things. I get that. But this is sort of what we're thinking is an initial step in that process. And so my current work uses all this, and this is funded. I'm very thankful to the NHLBI reviewers who were on my K group there who funded this. And so I've got 5 years to sort of work on this. And what we're doing is we're designing visual-based communication tool or tools that incorporate a visual image that's individualized and has scripted language for both the healthcare provider that's grounded in motivational interviewing and culturally centered. So we're going to actually build this ground up. We're going to, start by collecting some quantitative measures to see where people are at in terms of their threat appraisal and coping appraisal, and then work with them in focus groups, both the parents and healthcare providers, to sort of test some of the prototypes, build these tools ground up. After that, we'll determine sort of the acceptability and feasibility of these tools in a simulated clinical encounter, and then actually pilot test these in the actual clinical setting to determine its effect or change in threat appraisal, coping appraisal, intention to change, and short-term lifestyle changes as well. All right. So, again, our focus for this group is actually parents who identify as Black or from other minoritized families with the diagnosis of obesity. We're particularly or specifically targeting those who have a school-age child at home and identify as living in a low-income household. And really, we're also going to try, one of the things that, we're really focusing on the adults here because we have, tools that, can be used to express CVD risk score, but we're also going to try to attempt to communicate intergenerational risk. So whether that's using obesity as a measure or some other way, we're not quite sure. We're going to actually test some of those and get parent feedback on what they suggest. And this is sort of what I said as my hypothesis. I think that it can make some relevant, we can make some, a visual tool is highly visual and presented with scripted language that's highly relevant, may actually make changes across the whole family. So this is sort of largely more of what we're thinking here. I'm calling my tool ProCVD. Again, not a funny, it has an acronym, there's a whole acronym behind it. You can find me later if you're interested. But again, it's going to be paired later with the family-based behavioral intervention that works on all the other components as well. Here are some examples of some prototypes that we have started to design. This is a lot, and we're going to narrow this down. These are just different components that we have that are just kind of poured together here. You can see we've got health, heart risk scores, health indices, and we can sort of expand on some of these specific measures, using some of these tools as well. We may also incorporate, some of the other known tools out there using, the ACC or American College of Cardiologists Foundations, a lifetime and 10-year risk score. The essential 8 is something that we've also explored as well. And then we'll pair that with sort of brief behavior change counseling. Now, I mentioned building one or more tools, and that's because we're also going to test out some prototypes on using more individualized, images. specifically around, either I'm not quite certain if you want to do carotid endomomedial thicks or some other thickness or some other avenues as well, visceral adiposity or maybe some other individualized measure, but we may use some of those as well, and those are going to be tested again. We're going to ask our participants whether or not they think that that would be more or less helpful for them. So in terms of our expected outcomes, again, the development and assessment of one or two of these visual communication tools using formative research, and really we're going to pair the more salient tool in a future family-based behavior intervention, randomized control trials to sort of determine the effects on lifestyle change in both parents, children, and potentially even other family members. I have a whole host of career development goals for my own self, and sort of acquiring and applying some of these skills, really honing down on motivational interviewing techniques to make it really brief, and learning some of the skills around randomized control trials. So that I'm going to pause or stop there. I want to acknowledge the many mentors collaborators, team members that I've had, my current and past RAs in this lab, and then of course my funding sources as well. I'm happy to share my references. I appreciate you guys' time and attention. Feel free to reach out to me with questions, comments, concerns. I'm open to feedback. Thank you.